Today we are here to perform a physical examination on this patient's abdomen. Prior to, we took a health history, and the patient has said that he has had no change in appetite or difficulty swallowing. He does have a little problem with food intolerance, such as fruit. He experiences some tingling in his mouth and in his tongue, and therefore has a food allergy, so he just stays away from fruits. He has no abdominal pain, no complaints of nausea and vomiting. It does complain sometimes of some constipation, which contributes that to sometimes of the foods that he eats. Other than that, though, no other real bowel habits that are problems. No rectal conditions, no past history of hepatitis, appendicitis, colitis, or hernia. He is on no medications prescribed or over the counter. He does admit to having alcohol now and then, but no drugs, and used to be a smoker. He has since stopped smoking prior to the examination. And his nutritional assessment, 24-hour recall, he has had a chicken salad sandwich for lunch yesterday with a glass of water. For dinner, he had a piece of chicken, a double side of broccoli, no snacks at night, water throughout the day, and this morning had 2 pieces of toast along with a glass of orange juice. Now we're going to start the examination, and on the first part of the examination, I want to inspect the abdomen, inspect the color, the surface area, look for any jaundice, cyanosis, or redness, or bruising. I do not see any of this on this patient. Everything looks, the skin tones look good. There is no scarring. Looking at the venous return, I'm looking at the umbilicus and looking at towards the patient's head. Everything looks good here. As I move further down, I'm next going to look at the abdomen, look at the rib cage here. I'm seeing where the ribs are and where the rib cage is. Looking at the pelvic area and the pubis area. Everything is flattened. I'm also going to be looking and make sure that everything is symmetrical. Everything is lining up here. The umbilicus is in the middle. There is no distension or bulges. I'm also going to ask the patient, could you please take a deep breath? Okay, by doing this, I'm looking to see for any masses or hernia. I'm also going to ask the patient to raise his head. Could you raise your head? Looking at the abdominal wall again, looking for any hernias or any type of masses. Everything looks okay. Now I'm going to ask the patient to just lay flat, okay, and I'm going to look for any type of movement where the aorta would be, the lower aorta here, or looking for any surface motion from peristalsis. Looking for any aortic pulsation in the midline here. Pulsations, if they're visible, may suggest problems there. Okay, also moving down now, I'm going to get ready to auscultate. We auscultate first because we do not want to palpate or do percussion. We don't want to stir up the stomach and get things moving there that would cause any false sounds coming on with the auscultation part of the assessment. What I'm going to do is I'm going to auscultate the aorta area and all the quadrants of the stomach. Okay, everything looks good here. You'd want to hear some gurglings from anywhere between 5 to 35 per minute. There's no unexpected sounds like high-pitched tinkling sounds or decreased bowel sounds indicating possible obstruction. The abdomen is smooth and soft. I'm also going to move on to listen to for the liver and the spleen. I'm going to use the diaphragm and the belt. Okay, this is done because I want to listen for any friction rubs over the spleen or the liver. I'm also going to listen to the iliac arteries and the renal arteries and the femoral arteries. Okay, this is done because we want to check for bruits over the aortic, renal, iliac, or femoral arteries. And you listen for any bruits, which would be turbulent sounds, or any low-pitched venous humming sound, indicating some kind of issues going on. Moving on, we are going to now perform percussion, which is using your index finger or your middle finger and you pushing down onto your other middle finger and listening for tympany, which would be heard over the stomach or intestines, or dullness over the other organs or solid mass. So I'm going to do that in all four of the quadrants. I'm also going to do that over the liver area to determine the lower border of the liver, percussing up from the area of tympany along the midclavicular line. And I'm going to mark the point where renaissance changes to dullness, which occurs at the 5th to 7th intercostal space. And measuring that, that should be anywhere between 6 to 12 centimeters. We're also going to percuss over the spleen. You normally may hear a small area of splenic dullness from the 6th to 10th rib. Also want to percuss the lower intercostal space, left anterior axillary line. If the patient takes a deep breath, can you take a deep breath, please? You should not be able to palpate or feel the spleen. If you were able to feel the spleen, that would be cause some type of inflammation with the spleen. Okay, I'm moving on to palpitation. Just going to lightly palpate, looking at all the quadrants first, having the patient, relax, letting them get to some, the feel of warming my fingers here and the feel for as I'm running up and down here their stomach, so they get used to what's the feel of my finger. I'm just going to palpate the different areas. Do you have any pain?
No.
Any pain there?
No.
There.
No.
Okay. I'm also going to do deep palpation, in which I'm going to assess all the quadrants. Any pain?
No.
Any pain?
No.
Any pain?
No.
Any pain?
No.
So I'm going to palpate the liver. You can take a deep breath. Okay, the liver should feel firm and even and non-tender. I'm also going to palpate down and see if I can feel it where the gallbladder is. Okay, I don't feel that because a healthy gallbladder should not be palpable. For the spleen, I'm going to press over the left costal margin as the patient takes a deep breath. Can you please repeat that? Okay. Again, the spleen should not be palpable. Running my fingers down the side, I'm feeling for the patient's kidney area. Okay, moving on, I'm going to inspect and assess for ascites. Okay, this patient has no ascites here. You can see that. Patient denies any pain. I'm also going to assess for rebound tenderness. One of the signs I'm going to do is Murphy's sign. I'm going to have the patient take a deep breath. Can you take a deep breath? Okay, I'm going to be in the very upper quadrant. I'm palpating here. Do you have any pain?
No.
Okay, patient has no pain. Moving on for McBurney's point, it would be super iliac spine and the belly button on the side here. Rating this area 2/3 down. Assessing for the appendix. Do you have any pain?
No.
Okay. I'm also going to do rebound tenders where I push in hard and out. Do you have any pain?
No.
Okay. I'm now going to move the patient's knee up, looking for the sign of iliopsis. I'm going to lift the patient, bend his knee. Do you have any pain?
No.
Okay, I'm going to have the knee go down. I'm now going to also test for the arbitrator, which I would have the knee and have that flexed, rotated in, rotated out. Do you have any pain in this area?
No.
Okay, if you had pain at McBurney's point, you could possibly have problems with your appendix and possibly have appendicitis. Okay. I'm also going to ask the patient while checking for any type of fluid to, may I have this hand too? If you could put your hand somewhat like this, okay, and I'm going to hold my hand on this area and a little sternly here, push onto the patient's other side and see if there is a ripple in effect indicating possible fluid. Okay, no fluid in the abdominal area. Okay, and that concludes this assessment of the abdominal area. And I'd like to thank this patient for taking the time and helping me. And I'm very glad that everything is good and there are no problems and no masses and no venous problems. Thank you very much.